community team, so seeing patients in their own home. Along with my colleagues who work for Cardiff University, whose names you can see there on the screen, we are providing this palliative care webinar series to support all of those who are out there looking after palliative care patients in what is setting up to be quite a tricky winter, I think. So this is the third of our webinars in the series, and we're going to talk a little bit about out-of-hours palliative care in the community. So the webinars are free. They will be recorded and will be available for the participants to watch at your leisure if you're not able to join now, and we'll also provide copies of the slides and an attendance certificate. Apologies, because of larger numbers of people, it's difficult to be able to interact and let everybody speak, but we'll use the chat function and questions. And all I ask of you guys who are joining really is that you please fill in your evaluations, because that will allow us to potentially run further sessions with the university if we can see the value. Thank you. Okay. So we're just going to talk a little bit about out of hours, but actually I'm guessing lots of you on the call work either out of hours, in hours, or in a combination of the two. I'm guessing that Tuesday lunchtime is not a fantastic time to catch people who mainly work in out of hours. So actually, I'm imagining that I'm talking to a lot of in-hours staff and talking to how you might plan for your patients to be looked after in the out of hours period. The webinars are aimed mainly at Cardiff and Vale staff, and I know that we've had lots of people join us from elsewhere in Wales and from elsewhere in the UK, and you're all really, really welcome. We're glad to speak to anyone who's looking after palliative care patients and that might benefit. There may be the odd thing that I'll talk about that is Cardiff specific, and then you might just need to check out how your local services are run and what your equivalent services are that are out there in your place of work. Okay. Those of you who've joined these sessions before, it's mainly been myself and my colleague Fiona Rawlinson talking. For this one, I decided that I didn't want to do the talking for an hour and would like to bring in some of the wider team that are all out there helping us to manage palliative care patients. So we're going to have a bit of a panel. I'm going to speak for about 20 minutes about a case, and then going to hand over to Emyr Jones, who's one of my colleagues, who's consultant pharmacist and National Lead for Wales Community Healthcare, to talk about medicines availability and a specific scheme that's going on in Wales at the moment. I'm then going to hand over to Ed O'Brien, who is the end-of-life care lead for the ambulance service in Wales, to talk to us about how we might help out the ambulance service when they're trying to deal with palliative care patients out of hours. And then towards the end, we're going to take questions to the panel, and they'll be joined by James Davis, who's a consultant in palliative medicine at City Hospice and a colleague of mine, and also Alan Weatherup, who is a very experienced GP who works with the Cardiff and Vale GP out of hours service. Thank you. Questions and answers on the panel, as we said, and on the chat function as we go along. If those of you who are more used to Zoom, please try to make sure that your chat function, you're sending your chat to the attendees as well as the panelists. Otherwise, it's only us that can see what you're saying. Okay, Charlotte, would you mind just launching the first of our 3 polls? I'm just asking everybody what their main role is. So GPs, GP trainees, district nurses, ambulance, palliative care, nurses, and Emyr for later, even though I think this was marketed at pharmacists, we haven't had any join, or not that they're admitting to anyway. So I think that's in keeping with our other webinars, is that most people are from primary care. Thank you. Thank you. So we've got 40% GP or GP trainees, 30% nursing, and we haven't broken that down particularly, and then some ambulance service, district nursing and palliative care team staff. If you could just launch the second one, Charlotte, thanks. Okay, and in what setting does everybody work? So are you mainly community, mainly nursing home, secondary care, or specialist palliative care? So most people are working in the community, which is good because that's who these webinars are kind of aimed at, I'd say. Thank you. So we've got almost up to 60% community there. Thanks. And the last one, Charlotte, if that's okay. Just wanted to ask people, do you work in hours only, out of hours only, or a mixture of the two? So it's looking like the majority of people work both daytime and out of hours. And there are some people that only work during daytime, but it will still be really useful for you to be listening to this webinar. Only 15% of people are out of hours only, and actually we haven't timed this at a good time to capture them anyway. To teach out of hours staff, we need to be teaching in the out of hours period. Okay, thank you. Okay. So I'm just going to focus on a patient to get what sort of things we're talking about in our minds. So this is Ivy. She's 86. She's got lots of comorbidities: heart failure, arthritis, chronic kidney disease, dementia, leg ulcers. Functions gradually deteriorated over the past year, and she now needs help to transfer. She can't climb stairs. She's not going out. She's been into hospital quite a few times in the last year with confusion query cause, a UTI, a chest infection. And each time she's come out, she's been generally a bit worse and hasn't regained her previous function. She lives with her husband, who's elderly, got children close by who are supportive, and has got some care going in from agency carers to help with washing and things. And her husband says that she's very upset and aggressive when she's in hospital because she doesn't know where she is. And I guess that's a function of her dementia and possibly delirium with the infections that have taken her in. So that's Ivy. And she's the sort of patient that those of us who work in palliative care, in primary care, in the ambulance service, in district nursing, she's the sort of patient that we might well encounter, especially in the out of hours period. Okay, so just bear Ivy in mind. Well, I'm going to talk more generally about the sorts of things that you might want to think about for patients like her when we're planning ahead for the out of hours period. Okay. So remember, most palliative care patients, well, most patients spend the majority of their last year at home. Most palliative care, especially in the community, is done by non-specialists. So family, friends, neighbours, GPs, district nurses, community pharmacy, agency carers, and the ambulance service. That's not an inclusive list. I'm sure there are more people, but they're some of the people doing lots of palliative care out there. And the out of hours period is 2/3 of the time. So to say, you know, sorry, we're closed and this is a service that only works from 9 to 5, you do need to think about who's picking up the work for the 2/3 of the time that you're not around, and have you planned adequately for that time. So before there's a crisis with Ivy or somebody like her, what sort of forward planning can you do? And I'd be really grateful if you could just use the chat function so that I can try and see your suggestions, also that my colleagues out there can see the suggestions. Thanks. So I would be grateful if one of my colleagues could maybe read out the sort of things that are on the chat, because I can't see the screen at the moment, and it's probably easier if I don't stop sharing at the minute. Is that okay?
I can do that, Jo.
Thank you.
So we've got oh gosh, the quicker people go, the quicker they disappear off the screen. The quicker people write. Fantastic. So we've got advanced care planning, advanced and future care planning, treatment escalation plans, think about preferred place of care and preferred place of death. Are the main ones on the chat function so far.
Okay.
Honest communication. That's a really lovely phrase. Amanda, honest communication.
Completely agree with that. Okay.
Anticipatory medicines.
Excellent. I'll let you tell me, Fiona, when we think we've reached saturation in our suggestions.
Yes, any more for any more. Roll up, get your fingers typing. Folks, anything else that people would do that hasn't been mentioned already? Because everybody might do slightly different things where you work. Just thinking around care as well is the other thing. Thinking of your list of who provides, who helps support people, family support. care and family support. And making it clear who to contact in case of issues. Otherwise, the default, as Ed will know, tends to be 999. Anticipate transition points, so points when care will change, needs will change. Donna Phillips mentions message in a bottle.
Yeah.
So that system. Okay.
Okay.
Yeah.
I think I'll carry on then. Thank you very much for brilliant suggestions there, and I think I would agree with absolutely all of those. Thank you. Okay, so this is a screenshot from Vision, which is one of the main GP systems and one of the main ones that's used in the Cardiff area. Within Wales, there's also EMIS, and elsewhere there are others. They all do similar things. I think certainly programmed into Vision is lots and lots of palliative care guidance. And this is just an example of what it can do. So accessing the palliative care guidance, it will give you a little list there of things that it might be useful to carry out for Ivy and people like her. Okay, things like identify patients for the palliative care register, advanced care planning, which may well take into account preferred place of care and death, resuscitation status, out of hours forms, possibly consider referral to the specialist palliative care team, although as before, we wouldn't necessarily see all frail elderly people who possibly could be within the last 6 months of their life. But certainly if they've got any specialist needs or if you require any help or advice, we'd be happy to do that. Anticipatory prescribing, as mentioned, discussion at palliative care meetings, and then planning for last days of life and things like bereavement thereafter. So there are many checklists. That's quite a useful one if you're a GP that's working locally. And I think that the similar checklists appear in EMIS for those of you who are using that as a GP system. Okay. So identifying patients, for any of you who heard the webinar from a couple of weeks ago, we used this slide. Would you be surprised if your patient died within the next 6 months? I think if it was Ivy, we wouldn't be particularly surprised. And then look at the general indicators like poor performance status and spending lots of the time in bed or in a chair, unplanned admissions, and she certainly fulfilled that criteria, and 2 or more advanced or complex conditions and multimorbidity. So those are the sorts of people that should be identified as potentially needing palliative care, advanced care planning, and possibly being suitable for the palliative care registers in general practice. With Ivy, you might then come down and look at the dementia column there, and she has had recurrent febrile episodes and been in hospital, but potentially doesn't meet those criteria quite yet, but she would be somebody with to go onto the palliative care register and to consider advanced care planning because of fulfilling the criterion 1 and 2 above. So identify the patients. If you don't know about them, you can't plan for them. Okay. And how do you ask about advanced care planning? Fiona spent an hour talking about this last week, so I'm not going to dwell on it for those of you who heard that, and for those of you who didn't, that session's recorded, as is mine. But the sorts of ways to ask about these things are using open questions. You know, is there anything you'd like to talk about today? The people that know patients best are often the best people to talk about future plans. Could be GPs, could be district nurses, could be palliative care nurses if they're going in. It actually could be the carers that they know really well, and it might be their families. Okay. You can use things like educated guesses, so you're worried about the future, or hypothetical questions, because that takes all of the focus off the patient themselves if they're not comfortable talking about all of these things or their family. So is there anything you think your family would like to know about? We would sometimes use sort of, you know, hypothetical scenarios. Things like, or when I have looked after other patients in similar circumstances, they have sometimes found it useful to think about where they would like to be cared for or what they would not like to happen to them, for example, going back into hospital. And lots of people would, you know, the term sorting out your affairs often means things like planning for the end of your life, writing a will, and thinking about what your wishes might be. My colleague Ian Back-Income-Tarv runs the wales.palliativecare.palcare.info website, which contains lots of useful information, including material about advanced care planning and the communication of it. So there's the website there. Okay. If you manage to make progress in advanced care planning, and it's everybody's business, and it's not, you know, it's often a process rather than a one-off event. But if you manage to talk to people successfully about their plans, then it's really useful to get something written down. And here are some of the documents that are available in Cardiff and Vale. So an advanced care planning record of plans and preferences, or for people who may lack capacity, a treatment escalation guide there on the right-hand side. It's not particularly important which form you use, it's just important to have these things written down and available for people to look at. So for example, Age UK has similar forms, and the Motor Neurone Disease Association has specific forms to motor neurone disease as a condition. If you have managed to help patients to write some advanced care planning documentation, you are then left with the difficulty of where to store it, how to keep it updated, and how to disseminate it to the people who might be interested in it. And that's a problem that in Cardiff we certainly haven't completely solved yet. But I would suggest that a copy with the patient's GP filed in their notes, a copy at home for them, possibly more than one copy for them so they could take one to hospital with them if needed, would be useful. Certainly some of the palliative care teams scan these documents in onto the electronic systems such as Welsh Clinical Portal so that they're available. And we haven't yet particularly solved the problem of how we might disseminate this information to people like the ambulance service. Someone mentioned message in a bottle earlier, and that's the green little bottle in the middle there, which is a Rotary Club, I think, initiative, where it's a little plastic bottle which contains an A4 form on which patients can put their details, their contact details, medicines, allergies, people to be contacted in an emergency, or anything they want on there really. So it might say, I have an advanced care plan, and yes, it might be difficult to stuff it into the little bottle, but that could say, and that is stored, and it might say where that's stored in their house. It might say, I'm not for resuscitation, and there is a form, and it might say where the form is. The Rotary Club message in a bottles are designed to be stored in the fridge, because most houses in the UK have a fridge, so in the door of the fridge, which is where they're meant to be. And then they come with two little green cross stickers, which you're supposed to place one on the door of the fridge to indicate that the bottle's in there, and one on the inside of your front door. And people like the ambulance service and other emergency services are trained to look for that and will know what that means, and will know that that means, you know, if you go and look in the fridge, there might be some useful information. Okay. So DNA CPR, this is a slide that I had in my previous talk. It's not the be all and end all of everything, but it is an important document to consider if you think that people may deteriorate at home. And that's a copy of the All Wales form that we have. It's guidance only and not legally binding. Not for resuscitation is a medical decision, but it must be discussed in context, and patients should have a right to know if they're not for resuscitation, even though they can't necessarily override a medical decision. So we have got an obligation to discuss this with patients and potentially with their families if they wish. And to not discuss it, you would need to believe that that would cause real psychological harm if, as a healthcare professional, you choose not to discuss that. Okay. There's a resource at the bottom, the talkcpr.com, which some of my colleagues have put together, which is really informative about DNA CPR and perhaps how to talk to patients about resuscitation. And actually, some people have used the resources on there to show to patients. There's little video clips of doctors discussing such things. So what if there's no DNA CPR form? I put this up because we've had lots of questions recently where I work, and a few questions on the previous webinars. So this is a quote which is from the Decisions Relating to CPR Guidance, which is a joint publication from the BMA, Resuscitation Council and Royal College of Nursing. And it's just acknowledging that there will be some people for whom attempting CPR is clearly inappropriate, and gives examples there: advanced stages of terminal illness and death where death is imminent, but there's been no formal decision made. There'll also be times when you might come across patients who are dying, or who obviously dying, or who have died. For example, rigor mortis is what the quote is giving us there. And in these circumstances, you know, it wouldn't be appropriate as a healthcare professional to start CPR, and any healthcare professional that makes such a decision should be supported by senior colleagues, employers and professional bodies. And I think as doctors, we're reasonably comfortable with that. And I know from talking to colleagues from an ambulance service point of view, certainly the senior people within the ambulance service feel that that should be supported. On the nursing side, it can be more difficult because anecdotally from talking to my nursing colleagues, they sometimes feel less confident about the senior support perhaps in making those decisions. But this is what is written in national guidance. Looking for other information about patients is always helpful. So this is a Welsh clinical portal for anyone who's working in Wales. There's often useful information on there, lots of clinic letters and documentation, and the summary of the GP record and their medicines would be available on there. Case note summaries are a recent addition, which would be cancer notes and palliative care notes. So if you were to open that and scroll to the end, the last entries from palliative care should be there. Will give you lots of useful information about the patients. And if you were to click on that other correspondence there, it's not labelled as palliative care, unfortunately, but that would give you a letter from me and show you that I had seen a patient, and hopefully there'd be useful information in there for you. Okay. So any of you who are working out of hours as a healthcare professional who don't have access to Welsh Clinical Portal, you probably need to just be thinking about why that is and whether your organisations could enable you to have access. I know that most of the out of hours GPs in Cardiff and Vale certainly have access. I know that it's being looked at for the ambulance service, and I know that it's being looked at for places like community pharmacy as well. So if you're trying to plan ahead for people like Ivy, you can fill in a handover form to GP out of hours, so that if they do get called about here in the middle of the night, they have at least got some information. And I think that's an example of our palliative care handover form, but the in-hours GP handover forms to out of hours are very similar and contain similar information. So that would tell you, you know, what the diagnosis is, where that patient would prefer to be, whether they've got anticipatory medicines, the name of their carers, and whether there's a DNA CPR in place, and sorts of summary information like that. So challenges for people who are towards the end of their life, people who might be like Ivy and who've got functional decline. You would want to have people like district nursing involved, and possibly allied healthcare professionals who can provide some care, provide some equipment, and also to help you manage people like her in a multidisciplinary way. Practical hands-on care would usually come from either agency carers or sometimes from hospice at home. So the actual physical, helping people to have a wash, get dressed, help them to eat, and that sort of thing. We wouldn't usually be looking at providing artificial food and fluids for people who are dying comfortably at home, but it's a major issue that families are often very anxious about and needs to be talked through. And if patients are poorly at home and are towards the end of their life, they often can't take their oral medicines, and you might need another route for medicines. We talked a little bit about subcutaneous medicines and syringe drivers last time. And so those are some of the things that and the people that you may need to help you looking after people like this. Okay, medicines, so anticipatory medicines at the end of life, and we'd often put these medicines in advance in case there's a crisis, to treat things like pain, breathlessness, agitation, nausea and vomiting, and increased respiratory secretions. There's a picture of the sort of drugs that we might have available, but they vary a little bit from patient to patient and from area to area. And if you want someone to be able to give those medicines and without needing another assessment by someone that can prescribe, then they would need to be prescribed in advance on a medicines chart. And sometimes if we're prescribing far in advance, we wouldn't necessarily want the chart to be filled in because we would want another assessment first. So it sort of depends on your situation and whether you're foreseeing a crisis or not. Okay. So where do you get medicines from? In Cardiff and Vale, you can find a designated pharmacy, but someone would have to go to the chemist. If it's out of hours, the GP out of hours hubs also hold a stock list of palliative care medicines. And if not, you can access medicines in this area from the hospital using a green GP prescription or a WP10. This is the protocol that you need, which contains all the information for Cardiff, and most places I know of around Wales and around the UK have got their own arrangements, which might be slightly different. If you work in the Cardiff area, this tells you where the designated chemists are, their opening hours, their Saturday and Sunday opening hours, their contact phone numbers, including mobile phone numbers, which was a COVID addition, because when they're very busy and dispensing lots of things, they don't get to answer their landline very easily. But if the mobile phone goes, they know it's something urgent, and I've had some good responses on that. And this is the stock list that we would use. So most of the medicines that you might need, at least urgently from a palliative care point of view. And there's just a little flow chart there. If you're prescribing anticipatory medicines and you're quite happy that you're prescribing them in advance, and if they take a day or two to come, then that would be fine. Then you can use their usual chemist. If you want them a bit more urgently, then you need to find a designated chemist which is open. And in that case, you can go down this route and they would provide the medicines. If the designated pharmacy is not open, then, as I said before, the out-of-hours service holds stocks, or you could access the hospital. But in the middle here, there's a scheme. So GEMP stands for Just-in-Time Emergency Medicines Packs. And that is a COVID scheme that lots of you asked me questions about last time. So I'm going to hand over to Emir, who's a colleague, in a minute or two to talk in detail a little bit about that. And you might, if you're planning for crises or thinking that patients are deteriorating or towards the end of their life, you might want to refer to palliative care. You might want to access specialist palliative care for advice. And locally, they are our contact details. Okay, so that's a whistle-stop tour, but back to Ivy, who's at home, and what is going to happen to her. So imagine that this were to happen to her. I'll try and move my screen so I can read. It's 2 o'clock in the morning. Her husband calls to say she's fallen. She can't get up. He's finding it hard to look after her, but he's upset at the thought of her going back into hospital. And on assessment, she's agitated, mottled skin, irregular, rapid breathing, low oxygen saturations, unrecordable blood pressure. So what are we going to do for Ivy? So I've said her husband calls, and I've deliberately not said who he's called because actually it could be any one of a number of people. It could easily be the GP out of hours service. It could easily be the ambulance service because he's dialed 999 and he's panicking. It could easily be the district nursing service because he knows the district nurses. They go and dress her leg ulcers, and they've left a folder in her house with the 24/7 number on it. If she's known, they might even phone palliative care. And actually, if it's 2 o'clock in the morning and her elderly, frail husband is panicking, he's going to phone all of those people, and he's going to phone them all in rotation until somebody answers and somebody's able to help him. So what are we going to do for Ivy? Well, imagine that nothing has been planned for her. So we don't know what her wishes are. There's no useful pieces of paper with a plan or a DNA CPR around the house. There's no special equipment. In fact, she's still going all the way back upstairs on her stair lift and sleeping in her big double bed. She hasn't got any special equipment. She's still only got her carer twice a day. And she hasn't got any medicines in the house. So what are we going to do for her? I think there are a few options, and you may disagree, but I think lots of people in that situation might be quite likely to suggest admission of Ivy to a hospital, because actually she's got to be somewhere where she is safe, and she's got to be somewhere where she can be looked after. And I think lots of us can see that admission to hospital actually might not be particularly beneficial for her. She looks like she may well be dying in the situation that I have described. And we know that even if not, she hasn't particularly benefited from being in hospital, and has been quite upset when she's been there because she's got dementia and possibly delirium and becomes aggressive when she's there. So I'm not saying admitting her is wrong, and you haven't got very many other options if there haven't been other plans made. But if we were to admit her to hospital, and she'd need ambulance transport to get there, wouldn't she? She's likely to die in hospital. She might even die in the back of the ambulance or waiting outside A&E without her husband and without her family, because of all of the restrictions that we're living under at the moment. So that's a possible scenario for her, isn't it? So taking that back a step, just imagine that Ivy's family, district nurses, GP, maybe palliative care, and all the people that have been involved with her, imagine that they've worked through the checklist and they have done as much as they can of this plan. So the district nurses have flagged up to the GPs, because they see her every day or two doing her leg ulcers, that she's deteriorating. The GPs have put her on their palliative care register. They've discussed her with the district nurses. They might have discussed her with palliative care at practice meetings. They've done some advanced care planning, and they've filled in some forms, and they've noted that she doesn't want to go back to hospital, and that, if at all possible, she would want to be home with her husband and family and looked after there. They've filled in an out-of-hours handover form, and they've prescribed medicines in advance, so subcut injectable medicines for her to have at home just in case there's a crisis. Okay. So then, at 2 o'clock in the morning, we may well still need the ambulance service to pick her up off the floor, but they would be able to put her back into bed, and we've hopefully planned for her to have things like a bed downstairs and some equipment. Then the district nurses could come, and they could give her some nursing care, and if needed, could give her some subcut injections for her agitation there and her irregular rapid breathing. She may well benefit from some things like midazolam and morphine. The out-of-hours GPs may well be called, but if they came, they would have medicines that they would use, and they would hopefully have had a handover form, and they'd have some information about Ivy, and they'd have services in place, and wouldn't have to admit her for her to get care. But just imagine we'd planned ahead, and her twice daily carer is going up to two carers 4 times a day, because she now needs a lot more moving and handling, and she's going to get the odd night sit. And imagine that her daughters have all been spoken to about how things are deteriorating, and so they have planned to come and stay at night and do that in a rotation and help her husband out. I hope then we can see that she may well be able to spend her last days peacefully at home. And which is what she's chosen, because we've asked and we know. And so that's why it's really, really important to plan ahead as far as we possibly can. Thank you. I put down questions and answers there. I'm not quite sure of the time. We're a little bit short on time, aren't we? I'm going to leave the questions and answers there, if that's okay. And I'm going to ask my colleague Emir to talk a little bit about the just in case emergency medicines packs. Emir, is that all right?
Yes, thanks, Joan. Brilliant. So I'm Emir, and I'm just going to give a brief overview of the just-in-time emergency medicine pack scheme, or the JEMP scheme. So I've seen on the chart that there's a difference between this scheme and the just-in-case box scheme. I think that's one of the confusion. This scheme is about just in time, so getting that medicine just in time to the patient when we've exhausted all other options possible. So this is one of the schemes we introduced in the initial surge period of COVID, which I'll focus on for the next 5 or 10 minutes. We also got the just-in-case boxes that we worked on with the ambulance service, which Ed will discuss afterwards. And we also got the new policy we did during COVID around reuse of end-of-life meds in a care home setting or a hospice setting. So that's another one of the initiatives we did during the COVID. Can you move to the next slide, please, Joe? Thanks. So very quickly, for those who don't know about the GEMP scheme, it started as I said, as an initial response to the COVID pandemic. And it was around due to the supply chain. We had concerns about the supply chain, and it started from actually with the discussions I was having with Ed with the ambulance work, that we were looking to produce 300 or so just-in-case boxes to put on these ambulances. But when we looked into the procurement side of things, we really struggled to get the full supply in. Medicines were either on back order or not available. So we had real worries about the supply chain of medicines, particularly for palliative care. So if we found it hard to get the stock in using NHS supply chains, then if things really kicked off, like we were being fed from colleagues in palliative care about what they were planning for, we were going to really struggle to get enough medicines to go around to cope with the potential demand. And what we didn't want is having to ask family members, carers, or actually nursing colleagues to having to travel around potentially multiple pharmacies to try and get the meds in. Particularly, it would be a challenge for community pharmacy to get hold of these stock. So we decided to plan for worst case scenario, and that's why we looked at this type of scheme. We needed to centralise stock if possible, rather than asking individual GPs or care homes to stock meds. We wanted complete visibility of the stock. So the only way of doing this would be to take it back centrally, so we had full visibility of this stock. And we'd also need to make sure that this stock was accessible and timely. So if we put end-of-life meds in all care homes like we would have liked to do, there'd be no way of getting this stock back. So they could be sitting unused, where there'd be a spike in another part of Wales. So we decided that we would centralise stock into key sites across Wales, which I'll speak in a little bit after. And we decided that there'd be 5 main hubs across Wales that would keep some stock for us. So the other thing we wanted to ensure was, our planning for worst case scenario was to ensure equity across Wales. We didn't want one patient in one health board having access to medicine and someone sitting in another health board having none. So if we were to bring stock back centrally, we would need to make sure that we could get those drugs back out to the patient in the shortest possible time. And we set out a target that we would get medicines delivered to any postcode in Wales within 2 hours of it being requested. This was quite a tricky target to achieve, but we teamed up with Health Courier Service Wales, who I feel like are the wheels of the NHS, and they made the drivers available 24/7 for us to achieve this target. So about the GEMP itself, it's a standardised box. It's made up in advance. It's a grab bag, if you like, containing the key palliative care meds. So it's got your morphine in there, it's got your midazolam, hyoscine, levomepromazine, haloperidol, and water. I think that's it. Yeah. So that covers all the key medicines we'd require end of life. So once the prescriber assesses an individual that they need medicines, then they can contact the single point of contact, so the SPOC. So this is managed by Health Courier Service Wales, and at this point then we kind of start the stopwatch, that once the SPOC is contacted by the prescriber, they will then contact the nearest hub where we've kept the stock of medicines. They'll communicate to this hub and also communicate to the driver, to the Health Courier Service Wales transport. And the transport will make their way to the hub, pick up the GEMP box, and then they will deliver that way to the patient's home whether it's in a care home or whether it's at home. And they can also, as Joe mentioned, the importance of a medicines chart, they can also pick up a chart on the way if needed, and that's all managed by the single point of contact. And the target is to do all of this within the initial 2 hours. So this was a scheme set up to try and conserve the supply chain and also provide that timely access to medicines when maybe business as usual process, like Joe mentioned, each health board will have their own plans. If business as usual fails, then we've always got this scheme as a backup then. So we rolled this scheme out from concept to national pilot across all health boards in Wales within 6 days, which kind of shows what can be done when all the barriers are taken away, and then we can all just pull together, because this type of thing would have probably taken a couple of months to do in normal times. Next slide, if you can, please, Joe. Thank you. Very briefly, I don't want to dwell on this, but the next couple of slides just illustrate the work we did with the logistics experts based in the military. Again, at the beginning of the COVID, we mapped out the population of Wales, taking into account key locations, the likes of your community pharmacies, who are likely to keep some stock at least, and the care homes, because we thought this would be the potential biggest users of the service. So it wasn't about putting a hub in each health board, it's about trying to be a bit more strategic about it to ensure we got the best coverage possible across Wales. Next slide, please. So this just illustrates total population on the left and population density on the right, and this is what the mapping showed us. The highest population and density was, as expected, the south of Wales, southeast. So we would need increased coverage here, and this is where the highest proportion of our care homes are as well in this area, which indicates what our expected high risk population would be. Next one, please. So this was the initial hub locations. We decided to keep our end of life meds, and the mapping showed us that we could deliver to any postcode in Wales within a 90-minute travelling time with these hubs, and we'd also have the additional cover for the high population density. Next, please, Joe. So as I mentioned, this is the pathway. So if a prescriber in the community or in hours, or usually it's going to be out of hours, has a situation that we can't get timely access to medicines, they can write a prescription, put a GEMP box, they can contact a SPOC, so that's the single point of contact across Wales, so it's just one number, send a digital image via the Hospify app, which I'll explain a little bit after. So take a picture of the prescription that you've just written, and then the SPOC will do the rest. They'll contact the hub, they'll contact the pharmacy, and get the medicines delivered to the place of need. So we had nowhere near the number of activations that we predicted with this scheme, which is good, which means that business as usual processes within health board areas has worked, and we've been able to preserve the supply chain as much as we can, and we haven't had any massive issues with the supply chain, which it was the instigator of this scheme. So some of the challenges has been to roll out during COVID. I'm still not convinced the right people on the ground are aware of the scheme. So there's probably a lot of work we need to do with the communication side of things. From the activations we've had, it's turned out to be a very rapid turnaround. So average time has been around 80 minutes, I think, from the time the prescriber contacts the single point of contact requesting the box to it being delivered to the patient's house. So if you think about the time that would take a family member to potentially go and pick up the script and go to a pharmacy, potentially multiple pharmacies, then with this scheme, we can keep our patient's family at home with their loved ones. So we moved away from the original aim of preserving the supply chain to actually, this is a responsive service and it can improve quality of life and ensure we can get timely access to medicines. Next slide, please. Yeah. So, as I mentioned, some key information regarding the scheme. It's all on the AWTTC website, which is on the next slide. But a few pointers. If we're going to use this scheme, I'd advise to download the Hospify app in advance and be familiar with that. So you can download it from the App Store, create an account, and then it's good then to connect with Health Courier Service Wales. So this means that, you know, when you're ready to use the scheme out of hours or in a rush, then all the technical bits are done, and that's all you need to do is just take a picture of the script and forward it to Health Courier Service Wales. The contents of the GEMP itself, I've mentioned the drugs that are in them. It's not possible to tailor the contents of the GEMP because they're prepared in advance and they are a grab bag. So there can be no substitutions and the quantities must be exact. And medicines not included in the box can't be supplied via this service. So it's important that all the information is on the website, that we get the prescription requirements right. And I think one of the most common delays for patients and carers in obtaining medicines is that prescriptions are not written to the full legal requirements. And I know that can be frustrating, but it's even more frustrating for pharmacists having to chase this up, and it does add delays and kind of hands are tied from pharmacies due to the legislation and post-shipment. So it's important that we have the quantities on the prescriptions in words and figures, and that, you know, directions should always include a dose. So as directed wouldn't be acceptable legally for a controlled drug, but 2.5 milligrams injected subcutaneously as directed would be acceptable. Next slide, please, Joan. I think that's it, actually. Yeah. So all the information is on the AWTTC website under the COVID end of life medicine service. So it's there to be used. And yeah, I'm happy to take any questions as we go along or at the end. So back to you, Jo.
Okay, thank you. I'm just going to carry on, if I can move the slides, and see if Ed O'Brien would be able to just give us a few minutes from the ambulance service perspective about out of hours and what people could do to help your staff out when they attend palliative care patients out of hours.
Sure, I'll be super quick because I'm conscious there needs to be time at the end for questions. So just to make people aware, from a background point of view, when we as ambulance clinicians are responding to a 999 call, we know absolutely nothing. We've pretty much just given the address. We rarely even get a name of the patient, and we so often just get one word on our computer screen as to why we're going. So if you think of our EV that Joe was talking about earlier, the likelihood is we'd literally just have fall. We just have a home address and fall, and that's all we know. So any information that you can leave in that property for when we get there is massively valuable to us. So when we're on scene, we don't have any electronic access. So Joe's mentioned Welsh Clinical Portal. Currently, we don't have it. The future, that's different, but at the moment, we can see nothing. So we're really reliant on old-fashioned pen to paper, anything you've left lying around. So if you're going to do an advanced care plan, because I know a lot of people are hanging their hat on advanced care plans at the moment, if I'm being honest with you, it seems to be everyone's doing them, but just have a little think about what's in that advanced care plan, because some of them are absolutely amazing and they're so useful to us. Some of them not so much. So what I'd encourage you to do is to sort of, after you've completed it, is reread it and then say, if this was me going to a person who I knew nothing about at 3 in the morning, is this a plan for them? So I've seen some ACPs when I've rocked up, which tells me about, you know, their dislikes of certain things, their likes of opera music, and, you know, how they love the dog and all that, which is really important to the patient, but it really doesn't help us as ambulance clinicians at 3 in the morning to try and keep them out of hospital if that's what's appropriate. So less is not more. The more you can put onto a document, the better for us. You know, we can spend those extra few minutes reading it. Don't forget as well, if you're going to use the ACPA, at no point during the ACPA does it give you the opportunity to say what the diagnosis is. So please include that, because why is this advanced care plan being done? It's useful to know what the diagnosis is. So if you look at the RBID, which is the one for no capacity patients, ACP RBID, that's got a box for diagnosis. For some reason, the advanced care plan doesn't. So please include the patient's diagnosed condition so we can be aware of that. If possible, try and talk about the sort of where you think they are on the disease trajectory within that plan. acknowledging that's always, it's not always going to be possible. But for some patients, you may be able to say, this is late stage or this is advanced or something along those lines. That's really helpful to us. If you anticipate future symptoms, document those for us, because that might be why we've called. So if we've rocked up to someone's house and they're experiencing breathlessness, but you've documented on this plan for us that they've got condition X, and you as the doctor or you as the nurse anticipate they're going to have breathlessness in the future, that's really helpful to us, because we could then start, take a step back and think, okay, so somebody anticipated this happening. This might not be such a surprise, but also then potentially put down possible management for that. So you might want to put, I'm anticipating Ivy's going to have breathlessness. She's written up for just in case medications, and you might want to give 2.5 Oromorph or morphine subcut, etc. So give us a couple of options as to what you think might be useful. Also, if others involved in care, so Joe's mentioned that as well. So if there's district nurses, specialist palliative care teams, family, whatever, try and record that as well, because they're somebody we can lean on to get some extra information. If there's an LPA for health or an ADRT, please let us know about that as well, because we haven't got any electronic access, so we'll only know about it if you've documented it somewhere. All of the stuff that I've mentioned, though, it doesn't have to be on an advanced care plan. So I've been to patients' houses where doctors have left really, really useful letters. They're literally just a Dear Mr. or Mrs. Paramedic letter, and they've just given everything we need. It doesn't matter to us if it's an ACP or if it is a letter, as long as the information's there, because none of them are legally binding anyway. So just try and share that information with us, and of course, put it in a place where we're likely to find it. So the two places we're likely to find it is, one, the message in a bottle scheme that Joe's already mentioned. And obviously, if there's too much document to go inside of that message in a bottle, just put a slip of paper saying you'll find all the information in wherever it is, in the cupboard or in the drawer or whatever. And the other place is the district nursing notes or the community nursing notes. So we'll always have an open of the nursing notes. So if you want to put something in the front of them, we're pretty much guaranteed to see it there as well. So that's, from information point of view, that's what we'd like to see if possible. And the other really key thing is give us some phone numbers. So, and make sure they're 24/7. So chances are we're likely to be called out of hours. So giving us the GP number is useful if we were there every day, but it's not going to work for us in the night or weekends, etc. So give us 24/7 numbers where we can talk to somebody who either knows the patient or can access records about that patient. If we call you, so you may or may not have had phone calls from paramedics in the past, we're calling you for shared decision making. We're calling you because we want to involve you in our decision making. What we're not going to do is we're not going to literally, as soon as we get there, we're going to phone and say, Doc, what shall I do? We're going to have done a little bit beforehand. So I think as ambulance clinicians, we're really good at spotting reversible causes, so things like sepsis and that's just our world, that's our bag. We're always looking for reversibles. It's when we can't find a reversible and we suspect it's likely, further disease progression, that's when we're most likely to ring you and say, Doc, can I discuss this with you? We might be looking for your input as to, is this what you expected actually, or is this something brand new? Could it be a hypocalcemia that we hadn't considered? And, you've raised that with us and that'll be really useful. Also, if we're going to give just in case medications, we'll always ring you first to say, Doc, this is what I'm being called for. This is what I'm seeing. This is what I'm proposing to do. Do you agree? So we're going to ask you for your opinion on that as well. When we ring you, we're going to give you OBS. So I know a lot of sort of palliative care teams, GPs, and that might think, why are you doing OBS on a dying patient? But what I'd say to you is we didn't know they were dying when we first got there. So us doing a load of OBS was us doing part of our triage process. So that's why we're going to give you a load of OBS. And once we determine they're like the end of life care, we're not going to carry on doing OBS. But it's just to sort of say, we're going to give you a load of OBS, a load of information, all the stuff we've gathered that's made us get to the point where we're ringing you. And I'll stop talking.
Thank you very much, Ed. Thanks. I'm sorry, it was me that took up the time. I know we haven't got much time for questions. Apologies. I'll hand over to Fiona or Charlotte, who's going to ask some questions for us.
Yeah, we haven't had any in the questions yet, so I would encourage anybody to quickly type in any questions now. You've got a fantastic panel open to you to pose any questions about the content you've just listened to, so type them in now.
While people are typing then, Alan, if you're there, is there anything that you wanted to say from somebody who works in the GP out of hours service? You're on mute at the moment.
Not anymore. Yeah. First of all, I've got to salute Ed for his summary of what the paramedics need, because he's really nailed it in terms of the essential information that a paramedic needs. And there's a lot of overlap between the paramedics and ourselves, because usually when that GP in the out-of-hours service goes to see a patient in the middle of the night or whatever time of day, it's almost always going to be the first and perhaps the only time that GP sees that patient. There are probably in Cardiff Vale about 20 GPs who regularly and routinely do home visits for the service. And so the chances of that GP having prior knowledge of the patient and knowing a bit of information about their ability to cope, their functionality is going to be relatively small. But the important thing from our point of view is, unlike my paramedic colleagues, we can get access to a lot of information, which is really useful. We have got access to WAS Clinical Portal, which is a brilliant tool, although it's much more awkward to get a hold of that at the patient's house. We do sometimes, if we have a chance, look up that information at the base, or if our triage colleague puts down that essential information from WAS Clinical Portal onto the information that's transmitted to us, to our laptops in the cars. That's actually a great tool. But the important thing is we are there for the patient. We make our palliative patients our first priority. They always go to the top of our list when it comes to visits. And the thing, I suppose the challenges for us are probably as much to do with medication as anything, because our last pharmacy shuts about 10 o'clock, 10:30, which means effectively from about 9 o'clock in the evening, it becomes next to impossible to get medications without a time-consuming process, either going back to our base to get medication or to take advantage of the GEMP scheme, which I think is fantastic. And you know something, I don't think that GEMP scheme is going to end at the end of our COVID pandemic. It's such a useful service. I think it's going to carry on. But really, that's all I've got to say at the moment. Medication, and of course, to an extent, yeah, the other thing is equipment. I always think it's really good that patients who are getting frail and getting near the end of life, that they get introduced to the district nursing service even before they need them, because that way the equipment and things can be thought about even before we get to the point where they're actually needed. I think that's all I'd like to say for the moment.
Thank you very much, Alan. Okay, does anybody have any other questions?
Yeah, we've had a question. How do we send the request for the JEMP?
Okay, I guess the easiest thing to say at this point, because we've got less than a minute to go, is it's really comprehensively laid out via the web link that Emir put on his slides, and we're going to provide those to everyone, aren't we? And I also put that link on my first seminar as well from 2 weeks ago about end-of-life care.
We've got another question which Fiona's typed a response to, but I'm not sure whether everybody can see it. How can we help the carer and enable the care to help us in this?
Do you want to say that your response, Fiona, as you've typed already?
Yeah, I've just been really saying it's a really good point, and I think part of it is just in involving the carers. Sorry, I put my camera on. Involving the carers as much as possible in communications up to this point, which takes us back to advanced care planning conversations and how important they are to try and sort it all out before there's a crisis. Involving carers is really important. There may not be time to get a complete answer on this. There's another question just about subcut fluids. Any quick signposts for support in talking with anxious family members who feel anxious about letting their loved ones die of thirst, particularly if they're at home and not in hospital? Any immediate time? My immediate thing is we just have to listen. It's a really natural concern that people have, and we need to listen. I don't know, Joe or James, anything else you want to add to that?
I mean, I think it's about explaining why or understanding what their concern is, I think, because everybody's concerns may be different, and just allaying their fears that there isn't really particularly any evidence either way. And I think there's in the communities that there's obviously the practicality of getting that done. So usually after open sort of conversation and exploring someone's fears and concerns, then usually there's a sort of a mutual coming to a mutual agreement as to what's best for that person.
Thanks, James. Yeah.
Any other questions now at the end, quickly? Yeah, type in.
I think I'd like to, can I just make just a very quick point in terms of what we're doing is looking at, I think, trying to predict early on, isn't it, people's trajectories and issues that may crop up. And I think there are some which are relatively universal in terms of people becoming more frail, so thinking about care, support for families, symptom control, but then there may be ones which are more specific to each individual person. So what we'd like to do is try and get to the point where we don't have to use the GEMP and an ambulance isn't called, but it's also recognizing that if that does happen, you can still salvage it, and those people don't necessarily have to go to hospital if you know that there are processes out there that can potentially stop that happening if that's what the patient wouldn't want. And I'm going to shut up.
Thank you, James. I can't see the time. I think we're probably coming towards the end, are we, Charlotte? If there's no other pressing questions.
We're 2 minutes over and there's no other questions.
Well, thank you very much to everybody for joining us. We will provide the slides. There's some resources and contact details for us. Please book on to the next sessions if you found that useful, and please, please, please fill in your evaluation forms. Thank you very much.
Thank you all. Have a good afternoon. Take care.